many times the real world data are different from what we've seen in the clinical studies, the big phase 3 studies. For example, we do have data in patients who have relapsed or refractory myeloma and have received 1 to 3 prior lines of therapy. And you can see that in the major studies like the KRD versus RD or the IRD versus RD, the median age is 64, for example, in the studies. But what we've seen in our clinical practice are patients who are more elderly. For example, in Greece, in our center, the median age of myeloma diagnosis is 69. So the median age of the relapsed refractory patient is more than 70, as you can understand, 72, 73. So they are 10 years more elderly from what the studies have reported. On the other hand, we have frail patients who do not participate in the clinical trials because the inclusion criteria of the clinical trials are more strict. So the frail patients with renal impairment, with heart failure, with arrhythmias cannot participate in such clinical trials. So the real world data that correspond to such group of patients, I think they are extremely important. And we have some data in this conference for real world from the INSIGHT study, which is a big effort to have what's happening in the different countries, what is the treatment algorithm that happens to these countries, what is the first line therapy, second line, third line therapy, and these are real world data. This is what's happening in the real world. So we have some data from the INSIGHT study suggesting that possibly an oral combination like ixazomib with lenalidomide and dexamethasone is used for the more frail patients, the elderly patients, and this is something that can be well tolerated. And the PFS that is reported by this real-world data is almost similar to what the phase 3 study for IRD, the Tourmaline MM001, has reported in New England Journal of Medicine 3 years before. I believe that real-world data are extremely important, and the community needs these data in order the doctors to decide what to do with the patient that they have in front of them, and many times this patient does not correspond to the patient population of the big phase 3 clinical trials.